All right. I think in the interest of time, we might just get started. A few more people trickling in. All right, great. Let's get going. Hi, everyone. So welcome to the fourth virtual ward round this year on stroke. I think I've met a lot of you before, but for those who I haven't met, my name is Victor and I'm a junior doctor working at the Royal Melbourne Hospital at the moment. And in these virtual ward round series, I'll endeavour to provide some practical insight into how theory learnt from medical textbooks can be used to solve real-world clinical problems. And in this lecture, I intend to take you through several real-world cases intended to elucidate the differences in presentation between the most common stroke syndromes and also give you a sense for how strokes are managed in the real-world setting. All right, so as you're no doubt aware, the virtual ward round series is brought to you by Teaching for Impact, a not-for-profit organisation with a mission to use education as a weapon to create meaningful social impact. So this year, all of our medicine lectures are being run as fundraising events for the Asylum Seeker Resource Centre, or the ASRC, which is the largest independent human rights organisation for people seeking asylum in Australia. We share in ASRC's belief that all asylum seekers deserve protection, respect, and a chance to rebuild their lives, and invite medical students from across the state and nation to join us in our campaign to make a meaningful contribution towards this worthy cause. So for those of you who are interested in keeping abreast of the tutorials and the lectures that our TFI Medicine team has to offer, just scan the QR code on the right. And as always, I want to keep these sessions relatively informal. So at certain points, I'll put some questions to the floor, and I'll love it if you could all contribute answers to the online chat, or better yet, unmute and share your thoughts, as learning is always fun, more fun and effective as a dialogue rather than a monologue. So a few more admissions. All right. So for this ward round, I thought, before we get started with the ward round, I thought it would be good to revise some basic theory on stroke, beginning with the anatomy of the circle of Willis. So as you're all no doubt aware, the circle of Willis is an anastomosis on the ventral or the inferior surface of the brain that forms a circle around the optic chiasm and the hypothalamus, and provides arterial supply to pretty much all of the brain. And put simply, the circle of Willis is formed by two main systems. So the vertebro-basilar system, also called the posterior circulation, which is shown here in purple. And the internal carotid system, also called the anterior circulation, which in this diagram is shown in green. So I want you guys to focus first on the diagram on the right. So as you know, the ascending order arises from the opening of the aortic valve and then becomes the aortic arch. The aortic arch then gives off three branches in succession. So firstly, the brachiocephalic trunk, which then divides to give the right subclavian artery and the right common carotid artery. And secondly, the left common carotid artery and then the left subclavian artery. So let's first focus on the vertebro-basilar system, or the posterior circulation. The vertebral artery arises from the first part of the right and left subclavian arteries, and then ascends up the neck through the transverse foramina of C6 to C1, and then enters the cranial cavity through the foramen magnum. So then from the foramen magnum, the vertebral artery runs up the brainstem. And now we get to the middle diagram. So then the right and left vertebral arteries then join to form the basilar artery, which then splits into the right and left posterior cerebral arteries, or the PCA. And so speaking of the PCA, the PCA hooks around posteriorly and runs mainly along the inferior surface of the temporal lobe to supply the posterior surface of the cerebrum. And branches of the PCA then supply the inferior surface of the temporal lobe and the medial surface of the entire occipital lobe. And the PCA territory includes, as you know, the primary visual cortex. So turning now to the internal carotid system. So, or the anterior circulation. So I want you guys to focus on the diagram on the right again. So we have the right and left common carotid arteries bifurcating in the neck at the level of C4 into the internal carotid artery and the external carotid artery. And then the internal carotid artery then ascends up the neck through the carotid canal at the base of the skull. And at the foramen lacerum, the internal carotid artery then does a sharp bend upwards, as you can see in the diagram here, forming this S shape, and then ascends up laterally towards the optic chiasm. So now we get to the middle diagram again. The ICA then bifurcates to give the anterior cerebral artery and also the middle cerebral artery, or the ACA and the MCA. So speaking of the ACA, it runs anteriorly and up along the longitudinal fissure to supply the anterior surface of the cerebrum. And then it hooks around the genu of the corpus callosum at the anterior end near the frontal lobe, and arches posteriorly to give off a number of named branches, like the pericallosal branch and the calloso-marginal branch. The branches of the ACA supply the medial part of the frontal lobe and parietal lobes right back up to the level of the parieto-occipital sulcus, which separates the parietal lobe from the occipital lobe. And this territory includes the primary motor cortex and the primary somatosensory cortex for mainly the lower limbs. And then finally, the MCA. So the MCA runs lateral through the lateral sulcus, also called the Sylvian fissure, between the temporal lobe and the frontal and parietal lobes to supply the subcortex. So in the subcortex, the basal ganglia, via some branches called the lenticulo-striate arteries. And then more to the surface in the cortex, it supplies the lateral surface of the cerebrum. And so branches of the MCA supply the lateral part of the frontal lobe, the parietal lobe, and the occipital lobe, as well as the superolateral part of the temporal lobe. And this territory includes the primary motor cortex and primary somatosensory cortex for most of the body, except for the lower limbs. As well as the parieto-occipital association areas and the language areas on the dominant cerebral sphere, which is usually on the left. So Broca's area in the frontal lobe and Wernicke's area, in the temporal lobe. So some less significant branches, but the ACA, MCA, and the PCA connected by some communicating branches. So the anterior communicating artery connects the two ACAs and closes off the anterior aspect of the circle of Willis. And the posterior communicating artery connects the PCA and the ICA and closes off the lateral aspect of the circle of Willis. So all of this anatomy we'll come back to as we go through our cases today. So a bit about stroke in general. As you all know, stroke is classified into two main types. Most strokes, so 80% of strokes are ischemic in nature, but 20% are hemorrhagic. Focusing first on ischemic strokes, so there are three main subtypes. Thrombosis is the first one, where a clot forms within an artery supplying the brain, resulting in obstruction of blood flow. And thrombotic strokes can be divided into large or small vessel. disease. So large vessel disease, so the large vessels include both the extracranial large vessels, so talking about the common carotid artery, the internal carotid artery, and the vertebral artery, as well as the intracranial large vessels, so the circle of Willis, and also the most proximal branches of the circle of Willis. So the main pathologies affecting the large vessels include atherosclerosis and also dissection. Whereas small vessel disease, so small vessels we also call lacunar vessels, and they refer specifically to intracranial penetrating arteries that arise from the distal vertebral artery, the basilar artery, the MCA, and the arteries of the circle of Willis. So the main pathologies here that affect the small vessels is a phenomenon called lipohyalinosis, which is a lipid hyaline buildup distally, mainly secondary to hypertension. So the second main category or subtype of ischemic stroke is embolism, where particles of debris originating elsewhere break off and lodge in an artery supplying the brain, resulting in obstruction to blood flow. So the overwhelming majority of embolic strokes originate from the heart and what we call cardioembolism. And cardiac sources include atrial fibrillation. It includes, rheumatic mitral valve or aortic valve disease, mechanical heart valves, and infective endocarditis. But often you can also get cardiac sources due to a patent foramen ovale as well. So you can. Yep.
Sorry, I'm so sorry to interrupt, Victor. I've just got a friend in the waiting room. She messaged me to ask to be let in.
No worries. Let me. Great. Yep.
Thank you.
No worries. As you know, when you have a patent foramen ovale, you can develop a DVT and then have the DVT embolize into the right heart, and through the foramen patent foramen ovale, it can get from the right heart to the left heart and cause a stroke that way. And the third main subtype is systemic hyperperfusion, so where you have a global drop in perfusion. The most common situation that I've seen this in is in the context of cardiovascular surgery. And this usually causes ischemia predominantly in what we call the watershed regions of the brain, where you get an intersection between the, for example, the ACA and the MCA circulations, which are particularly susceptible to global hyperperfusion. So there are two main subtypes of hemorrhagic strokes. The first is intracranial hemorrhage, where the bleeding occurs directly into the brain parenchyma. And the most common causes are hypertension, trauma, bleeding diatheses, amyloid angiopathy, and illicit drug use, so mostly amphetamines and cocaine. But you can also get subarachnoid hemorrhages, where the bleeding occurs into the CSF within the subarachnoid space that surrounds the brain. And the two most common causes there are berry-aneurysms and AVMs. But hemorrhagic strokes you'll find are actually mostly managed by neurosurgeons rather than neurologists. In the context of this being a stroke or a neurology ward round, I won't focus too much on hemorrhagic strokes. The focus here will be on ischemic strokes. So having said this, clinically we use the TOAST classification scheme for ischemic strokes, and the SMASH-U classification scheme for hemorrhagic strokes. And I'm not sure if you guys have heard of this classification scheme before, but the TOAST classification scheme divides ischemic strokes into 5 subtypes. So the first is large artery atherosclerosis, which is probably the most common cause. The second is cardioembolism. The third is small vessel occlusion, fourth is stroke of other determined etiology, and the fifth is stroke of other determined etiology, sorry, and the last is stroke of undetermined etiology. And often in managing stroke, first, in the acute phase, we want to stabilize the patient and get rid of the clot in the brain. But afterwards, we don't just leave it at that. We would want to actually dig deeper and determine the cause of the stroke. And often on a stroke ward round, you'll hear consultants, registrars refer to this TOAST classification. And trying to figure out exactly which subtype, which of the 5 subtypes in the TOAST classification a particular patient presenting with an ischemic stroke falls. And I know I said I wasn't going to focus on hemorrhagic stroke, but hemorrhagic stroke has a very similar classification called the SMASH-U classification, which divides hemorrhagic strokes into 6 subtypes. So it's an acronym. So S stands for structural vascular lesions, M stands for medication, A stands for amyloid angiopathy, S stands for systemic disease, H stands for hypertension, and U, just as in the TOAST classification, stands for undetermined. So with all this sort of knowledge in mind, let's get cracking with the ward round. So the first patient that we see on this ward round is Mrs. ST. So Mrs. ST is a 50-year-old lady who's been brought in by ambulance after a fall, background of a mechanical aortic valve replacement, for which she's on warfarin. She was very drowsy when she came into ED and wasn't speaking at all. And everyone thought that this was probably due to the drowsiness. The nurses reported that they thought she was moving the right side of her body less than the left, but she couldn't really be examined to confirm this because she was too drowsy and not following instructions. So the ED registrar thought that this was almost certainly going to be a hemorrhagic stroke. She had had a fall. She was on warfarin, which would make an ischemic stroke quite unlikely. And now she was really confused. So the ED registrar ordered a non-con CT brain, which is good at picking up, among other things, is good at picking up hemorrhagic strokes. And the non-con CT brain was completely normal. Now, on further questioning, Mrs. ST's husband said that she'd had an episode like this once before, and it had gotten completely better. I mean, the ED registrar, was at a loss for what this could be. Could this be a migraine, a very bad migraine? So called the neurology registrar. And the neurology registrar made the very important point that her drowsiness didn't completely explain her aphasia. So her eyes were opening, but she was literally not saying any words at all. And also the fact that she was moving the right side a little less than left was also quite worrying as well. And all these features to the neurology registrar pointed towards an ischemic stroke. So it's important to note that 60% of the time, ischemic strokes can't be picked up by non-con CT brain, which is usually the first investigation that you order. So one radiologic sign of an early ischemic stroke is something called the dense artery sign, which I've shown here on the right. And the dense artery sign refers to this increased radiodensity of an artery that's indicative of an embolic or an atherosclerotic occlusion of the artery. But 40% of the time, ischemic stroke can be missed by non-con CT brain. So the neurology registrar recommended a follow-up scan. So a CT angiogram to be performed, and a CT angiogram in a CT angiogram, the radiographer injects contrast through the veins, usually via peripheral line in the antecubital fossa, And then you can actually see the contrast going through the vessels. And if there's something blocking the contrast, then it will cause something called a filling defect. And this is how you usually diagnose an ischemic stroke. So sure enough, the CT angiogram showed a massive ischemic stroke. And I'm wondering whether people might hazard a guess as to what kind of stroke syndrome this would be. So drowsiness, aphasia, right-sided weakness. Yeah, left MCA stroke, and we'll get to this in a second, but it's a proximal or a M1 left MCA stroke. So let's talk about this a little more. So I have a diagram of the trajectory of the left of the MCA artery there. Sorry, I'm just going to let some people in. All right, so recall that the left internal carotid artery turns into the left MCA artery. And the MCA then goes through the subcortex to supply the basal ganglia via these lenticulostriate arteries, and then hits the cortex to supply the frontal lobe, the parietal lobe, and the superior parts of the temporal lobe. In this lady, a clot must have formed on her. So she has a mechanical aortic valve. So a clot must have formed on her mechanical aortic valve, which then embolized, traversing through the ascending aorta, through the aortic arch, up the left common carotid artery, up the left internal carotid artery, and lodged in the M1 segment of the left MCA. And to go into that in a little more detail, so the MCA can be divided into three segments. So there's the M1 segment, also called the horizontal segment of the or the sphenoidal segment of the MCA, and this is the segment that gives off these lenticulostriate arteries supplying the basal ganglia. And then after that, the MCA then usually bifurcates into upper trunks and lower trunks, which we call M2. Sometimes it trifurcates into an upper, middle, and lower trunks. And this is what we call the M2 segment, and this is the segment that traverses through the insular cortex, and then once it gets onto the surface of the cerebrum, we call it the M3 segment. So the M3 segment begins at the external margin of the sylvian fissure, and then it extends distally away on the cerebral cortex. So when you get a clot in M1, you pretty much knock off this entire territory. So you're expected to present with both subcortical signs and cortical signs. So the subcortical sign in this patient is drowsiness. So you've knocked off the basal ganglia completely, and so this patient has presented with an altered conscious state, which is a subcortical sign. And then you also knock off these, the supply of these distal branches as well. So you expect, so in addition to drowsiness, you expect contralateral hemiplegia, because you've knocked off the motor fibers as they travel through the subcortex, and also once they've hit the cortex. And usually patients with M1 stroke have very, very dense hemiplegia. They can't move their contralateral arms and legs at all. And associated with that, you get contralateral hemianesthesia as well, because you've also knocked off the sensory fibers as they travel through the subcortex, and also once they've hit the cortex as well. You also get this a gaze deviation away from the side of the weakness towards lesion, because you've knocked off the centers of lateral gaze in the frontal lobe. So it's like the patient can't bear to look at the side of weakness, and it's like that weak side of the body doesn't exist for them, and it's part of this hemi-neglect phenomenon. If you've had a left MCA stroke, in most people, the left hemisphere is the dominant hemisphere, so you expect to get some language deficits as well. One thing that you should bear in mind is that it's not possible to correlate handedness with the location of language centers. So even if you're left-handed, chances are your language centers are probably still in the left hemisphere. So most people have their language centers on the left. So a left MCA stroke can knock off Wernicke's area in the temporal lobe. And if you knock off Wernicke's area, you get a phenomenon called Wernicke's aphasia. And what does that usually present with? And how is that different from if you knock off Broca's area in the frontal lobe, causing Broca's aphasia? Yeah, great. So Wernicke's aphasia is the eponymous name, but we call it receptive aphasia, so difficulty understanding or receiving language. And Broca's aphasia is also what we call expressive aphasia as well, and it's difficulty expressing yourself, so difficulty producing language, resulting from you knocking out Broca's area in the frontal lobe. So that's if you have a left MCA stroke, and if you have a right MCA stroke, you can present with hemi-neglect. So it's like the contralateral side of the body doesn't exist, and the patient simply ignores that side of the body. So I have a question. So an M1 infarct is quite a serious infarct because it's quite a proximal branch of the MCA. So you knock off a much bigger sort of territory than say if you have a clot that lodges in the M2 segment. So if you block the just proximal to the MCA, so if you block the internal carotid artery, would you expect an even more severe deficit than this one? So yeah, that's right. That's right. It's not so it's not always the case that if you block more proximally, you get a more severe deficit. So if you block off the cerebral circulation early enough, at the level of the internal carotid artery, you actually have enough collateral supply that the patient would mostly be asymptomatic because the territory that's usually supplied by ICA is supplied also by other arteries as well, and so doesn't suffer the same level of ischemia. So you can get patients with like 95% occlusion of the left MCA and 100% left ICA and 100% occlusion of the right ICA and be completely asymptomatic. So there's no part of the brain that's completely dependent on the ICA, and it's only really that when you occlude the middle of the cerebral circulation. So for example, the M1 segment of the MCA, that you can get quite devastating consequences, because the M1 segment, it's early enough that many parts of the brain are dependent on it, and it's late enough that there isn't any sufficient collateral supply. So that's M1 MCA strokes or proximal MCA strokes. So you go around to the next patient, and the next patient is Mrs. UV. So Mrs. UV, she's a 70-year-old female who was brought in by ambulance because of sudden onset right upper limb weakness and difficulty talking, which began 2 hours ago. And as she was being wheeled through the ED on the way to the scanner, the ED registrar noted that she hadn't dropped her conscious state at all, in sharp contrast to the previous case. She remained alert, but she had a facial droop, dysarthria, and right-sided quadrantinopia. But her right lower limb was relatively spared. So the ED registrar actually needed to get most of the history from the husband because of the dysarthria, because Mrs. UV was having difficulty getting her words out. What kind of stroke could this be? So right upper limb weakness, right facial droop, dysarthria, and right-sided quadrantinopia, but no decreased conscious state. So this sounds like an MCA stroke, but the fact that the patient isn't presenting with subcortical signs, so decreased conscious state, suggests that the occlusion is actually distal to the lenticular striate artery supplying the subcortex. So the basal ganglia isn't affected. So it's beyond M1, so M2 and M3, as Sybil mentioned. So it kind of sounds like the previous presentation, but not as severe as the previous presentation. So in this case, it ended up being a left M2 superior division stroke. As we were talking about, you have the M1 segment of the MCA travels through the subcortex and then gives off these lenticular striate arteries to supply the basal ganglia in the subcortex. And then afterwards, it usually bifurcates into an upper division and a lower division. And in this case, it's a clot that's lodged in the superior division of the M2 segment. Now, the stroke here consists of so sensory motor deficit in the contralateral side of the body, but contralateral face and arm more so than the legs, because the MCA territory includes the primary somatosensory cortex and this primary motor cortex, supplying mainly the face and the upper limbs rather than the lower limbs. Like before, you get gaze deviation away from the side of the weakness towards the side of the lesion. And in this case, because we've clotted off the superior division of the M2 segment, there's a visual deficit that we can expect in this patient as well. Can you guys hazard a guess as to what this might be? So you get so everything is opposite. So if you clot off the superior division of the M2 segment, patients tend to present with a contralateral inferior quadrantinopia. And also because of it's on the left side, we knock off the Broca's area as well, and we get not complete aphasia as we get from an M1 segment stroke, but a Broca's aphasia, which is like an expressive aphasia with patients presenting with difficulty producing language. This patient, had quite broken speech, broken speech, but they just couldn't sort of get their words out, but they were able to follow three-stage commands without any issues, because they could understand what was being spoken to them. So compared to an M1 segment stroke, an M2 segment stroke or beyond results in no impairment of conscious state because you haven't affected the basal ganglia. The clot is distal to the to the subcortex, so you only present really with cortical signs. And there's also usually the sensory motor deficit spares the legs, so it's more prominent in the arms and the face. So, you know, Mrs. UV had a left M2 superior division stroke. Obviously, you can also get a left M2 inferior division stroke, although this is much rarer. And the main difference with the M2 inferior division is that it causes, rather than a Broca's aphasia, causes a Wernicke's aphasia or a receptive aphasia with patients presenting with difficulty understanding language. These are the patients with what we describe as word salad. So they're saying a lot of things, but none of these things actually, none of the things they say actually make sense. And again, everything is in opposites. So if you clot off the inferior division of M2, you get a contralateral superior quadrantinopia. It is possible for the clot to occur further downstream of the MCA as well in the M3 segment, but as you go more distal, because the vascular territory is getting smaller and smaller, you present with less and less severe symptoms. So sometimes you can get just you know, if you clot off the M3 segment, you can just get a pure motor deficit that's limited to the face and arms. You can get just pure Broca's dysphagia. You can get something called a cortical hand, where just the hand is affected rather than the whole upper limb. You can also get something called a conduction aphasia. So the Broca's area is intact, the Wernicke's area is intact, but the tract between Broca's area and Wernicke's area is affected. So these patients tend to present with difficulty hearing words and then repeating the words immediately back. So that was M2 segment MCA strokes. So the next patient is a 60-year-old man who was brought in by ambulance because of difficulty walking, as well as urinary incontinence and confusion. Now, I want to just stop there. When you think of when you hear a triad of symptoms consisting of difficulty walking, urinary incontinence, and confusion, what should you be thinking of? Yeah, so it's the wet, wobbly, and wacky. So yeah, normal pressure hydrocephalus is classically presents with this triad. So unfortunately, in this patient, a code stroke wasn't initially called, but your fellow resident who saw this patient in ED at the time knew that time course was important, and discovered on history that these symptoms actually had quite a sudden onset 2 hours ago. And so she sort of, you know, knew that time was brain and decided to call a code stroke. And while she was waiting for the stroke team to arrive, your colleague actually noticed Mr. WX actually had an isolated right lower limb weakness. So he didn't actually seem confused. He was able to follow instructions quite well, but just had difficulties expressing himself. He couldn't talk, but didn't seem too fussed by it. So it's not classic for Broca's dysphagia, where you know, people can't express themselves and become quite frustrated about this. I'm wondering what you guys think this could be. Could it still be normal pressure hydrocephalus? Yeah. We'll get. We'll talk a little bit about. So I think the reason why this story, although it's the classic triad for normal pressure hydrocephalus, isn't entirely convincing for normal pressure hydrocephalus. Is that normally normal pressure hydrocephalus, the triad presents quite insidiously. So this is acute onset 2 hours ago. Usually normal pressure hydrocephalus, you don't get that. Now, just a word on normal pressure hydrocephalus. So it's a form of communicating hydrocephalus. Do you guys know the difference between a communicating and a non-communicating hydrocephalus? So it's as the name suggests. So communicating hydrocephalus means that the ventricular system is all communicating. So there's no obstruction. So the obstruction isn't in the ventricular system. It's usually at the level where the CSF tries to get out from the ventricular system through the arachnoid granulations. And non-communicating hydrocephalus is when you get an obstruction of a stenosis within anywhere in the ventricular system, causing dilated ventricles. So it's a form of communicating hydrocephalus. So there's no obstruction within the ventricles, but you get pathologically enlarged ventricles with normal opening pressures on LP. And the expansion of the ventricles distorts the fibers of the corona radiata, leading to this triad of urinary incontinence, gait disturbance, and cognitive dysfunction, or what we call wet, wobbly, and wacky. So patients with normal pressure hydrocephalus don't necessarily need to have all three cardinal features. So usually gait disturbance is the most prominent feature. Do you guys know what kind of gait disturbance patients with normal pressure hydrocephalus usually have? So how do they walk? Yeah, so the gait disturbance is variously described as a magnetic gait or a glue-footed gait. So the functional sort of limitation is that patients have difficulty, turning and take several steps to turn 180 degrees or 360 degrees, and this is when they're most vulnerable to falls, when they're actually trying to turn on the spot. And yeah, we got cognitive impairment, which can evolve over months to years. As I say, it's not an acute onset. Usually, the cognitive disturbance develops after the onset of the gait disturbance, and you can present with both subcortical and frontal features. So you can get psychomotor retardation, decreased attention and concentration, or frontal features like impaired executive function, apathy as well. And the urinary incontinence usually just starts off as urinary urgency, but then you get this gait disturbance as well, which delays patients reaching the bathroom in time. And in the later stages of NPH, because you get that cognitive impairment as well, urinary incontinence is often accompanied by a lack of concern. So they're urinarily incontinent. They wet themselves in bed, but they don't really care. Do you guys know how, if you have a patient that presents insidiously with the three, cardinal features of normal pressure hydrocephalus, what is the next test that you do on these patients to actually nail the diagnosis? Yeah. So the next important test is actually an MRI, MRI brain, if you haven't done that already. And do you guys know what the classic finding on MRI brain would be for patients with normal pressure hydrocephalus? Yeah. So enlarged ventricles, but not due to atrophy of the brain. So often you can get ventricles being enlarged Yeah, that's right. So often you can get ventricles being enlarged, you know, with age, because with age you get cortical atrophy, and then, you know, relatively speaking, the ventricles look enlarged. But the hallmark feature is you know, enlarged ventricles in the absence or out of proportion to sulcal enlargement, as Sean mentioned. And do you guys know what the treatment for normal pressure hydrocephalus would be? Yeah. So for some patients, VP shunts work, and they work by, you know, diverting the CSF, you know, from the lateral ventricle into the abdomen. But the important thing to note is that not all patients with normal pressure hydrocephalus actually improve after shunting. So to identify those more likely to respond to shunting, we look for two things. So one is an MRI finding, and the other is a ward test that we do. So the first sign that we look for on MRI is a sign called DESH. So DESH, which stands for disproportionately enlarged subarachnoid space hydrocephalus. And this will usually be commented on the MRI report. And patients with this DESH feature have been shown to be more likely to respond to VP shunting. And then there's another confirmatory test that you do on the ward called a lumbar tap test. And I'm not sure if any of you guys have seen this on the ward, but basically it's done in conjunction with the physios on the ward. So you first ask the physio to assess the patient's baseline gait function. And they do all sorts of tests, 6-minute walk tests. They turn the patient to see how many steps they require to turn like 360 degrees, et cetera, et cetera. They get a baseline, and then you do a lumbar puncture on the ward. And this is in contrast to sort of your stock standard lumbar punctures, where you probably only, you know, need to take off, you know, a maximum of 10 mils of fluid. In a lumbar tap test, you take off a lot more fluid, so you know, 30 to 50 mils of CSF, and then within half an hour to 60 minutes, you get the physios to do another set of gait function tests. So exactly the same test as before, 6-minute walk test, or get patients to turn on the spot and see how many steps it takes for them to turn 360 degrees. And if there's an improvement after the lumbar tap tests, and the physios have documented that, it's been shown to be associated with a better outcome after placement of a VP shunt. So if you have a patient with the classical triad of gait disturbance, cognitive impairment, and urinary incontinence, with an MRI brain showing, you know, DESH and a positive lumbar tap test, you can diagnose the patient with normal pressure hydrocephalus. And because there's DESH and there's also a positive lumbar tap test, the patient is quite likely to respond to a placement of a VP shunt. And the next step is to refer the patient to the neurosurgeons to organize a VP shunt insertion. And usually, if you carefully select the patients using DESH and DESH criteria and the positive lumbar tap test criteria, usually shunting leads to a sustained response in about 2/3 of patients with normal pressure hydrocephalus. But the distinction in this case is that you know, all of this actually came on quite suddenly for our patient, and which points more to an acute pathology like a stroke. And someone did mention an ACA stroke. So Mr. WX did in fact have a left ACA stroke. As we've talked about, the ACA comes off the ICA and supplies most of the frontal lobe as well as the corpus callosum and parts of the basal ganglia. So the main thing is that it supplies most of the frontal lobe. And you know, ACA strokes are quite rare. The ACA also supplies part of the homunculus representing the legs as well, which is why in an ACA stroke, as opposed to an MCA stroke, you get leg weakness rather than face or arm weakness. So the clinical features of an ACA stroke So you get, in contrast to an MCA stroke, you get sensory motor deficits of the contralateral lower limb more than the upper limb and the face. You get urinary incontinence. And because the ACA supplies most of the frontal lobe, you tend to get these frontal lobe signs as well, and symptoms. So things like, lack of spontaneity, strange behavior, lack of motivation or willpower, just not really caring. And if you have a left MCA stroke, you sometimes can get a Broca's dysphagia as well, because you're affecting the frontal lobe. There's also this thing that you can get called an alien hand syndrome, and the technical term for it is sympathetic apraxia. So this is a super weird symptom where patients feel like one of their hands is not under their control. So the hand is just doing its own thing. Often the movements are quite can still be quite purposeful. So there have been instances documented where patients who have suffered an ACA stroke can wake up in the middle of the night with their alien hand strangling them because they don't feel that they have control over it. So going back to the principle that it's sometimes better to have a more proximal occlusion. This applies to ACA strokes as well. So if you have an A1 stroke, that's usually okay because the collaterals will save the day. Most patients with A1 strokes remain asymptomatic. It's really when you get to A2 or A3 that you start to get these symptoms that we talked about. So sensory motor deficit to the contralateral lower limb, frontal lobe symptoms, urinary incontinence, etc. So a quick break. So what were the 5 TOAST subtypes of ischemic stroke? And again, feel free to use the chat function or to unmute and just shout out the answer. So 1 is large artery atherosclerosis, which is the most common subtype. Secondly, cardioembolism. 3rd, small vessel occlusion. 4, stroke of other, determined etiology. And 5, stroke of undetermined etiology. So the 6 SMASH-U subtypes. So SMASH-U is an acronym. So S stands for structural vascular lesions. M stands for medications. 3, amyloid angiopathy. 4, systemic disease. 5, hypertension. And U stands for undetermined. If you occlude the M1 segment of the middle cerebral artery, what would you expect patients to present with? So you get subcortical features, so impairment of alertness. So you get altered conscious state. You get, contralateral hemiplegia. You tend to get a global aphasia if you have a left-sided lesion. And if you have a right-sided, M1 segment occlusion, you tend to get this hemi-neglect syndrome as well. How does an occlusion of the superior division of M2 segment of MCA present? So in contrast to an M1 stroke, there's no impairment of alertness because it's distal to the lenticular striate arteries that supply the basal ganglia. You get a dense sensory motor deficit in the contralateral face and arm, more so than the legs. And you get this ipsilateral deviation of the head and the eyes. Inferior division of M2, you tend to get, Wernicke's dysphagia rather than Broca's dysphagia, and you get a superior rather than an inferior chondroantenopia. And ACA, because the ACA supplies the frontal lobe, you tend to get these frontal features, disorders of behavior, urinary incontinence, and also because the ACA supplies the primary areas of the primary motor cortex and the primary sensory somatosensory cortex, supplying the legs rather than the arm. You get sensory motor deficit in the leg more than the arm. So, and also you can get, if the Broca's area of the frontal lobe is affected as well, you can get a Broca's dysphagia. What's the classic triad for normal pressure hydrocephalus? So it's wet, wobbly, and wacky. So wet stands for urinary incontinence. Wobbly stands for gait disturbance, and wacky stands for cognitive impairment. And how do we identify patients with normal pressure hydrocephalus who are more likely to respond to shunting? So the first is DESH, so that branch, and because the visual fields is switched around, you get a contralateral inferior loss of vision in the contralateral inferior quadrants. All right. So the next patient that you see, Mrs. YZ, is a 70-year-old lady with some vascular risk factors who presented with sudden onset severe weakness down the left side. So having seen all the FAST campaigns in the community, she was worried about a stroke and immediately self-presented to the ED. But her only symptom really was weakness, but appropriately at the triage in ED, a code stroke was called, and she was rushed to the scanner. And on the way to the scanner, the neurology registrar did a neuro exam, and there was really nothing else to find except weakness. So everyone looked at the non-con CT brain in search for the hypertense artery sign, but saw nothing. She then got a CT angiogram, which looked for a filling defect. And again, there was nothing. She then got a CT perfusion scan, which looks for a perfusion defect. And again, it was unremarkable as well. So the neurology registrar then called the consultant, and for advice, even though all the scans were normal, the consultant pretty much told him that if you think it's a stroke, you should thrombolize the patient. So even if you can't see it on the three CT modalities, you should still thrombolize it if you're suspecting a stroke. So the neurology registrar thrombolized her anyway, and a few days later she'd gotten better. And often, so CT brain is the quickest scan that we can get, but it's often days after the initial presentation that we're able to secure an MRI scan. And the MRI scan showed that she indeed had a stroke. And as you know, an MRI brain is more sensitive than a CT brain for detection of ischemic strokes. But where do you think the stroke would be? Yeah. So pure motor stroke, suggestive of a lacunar stroke. So this patient had a lacunar stroke. Lacunar strokes are often not detected using CT. And as I said, they often present with pure motor signs. So the lacunar stroke comes from the lacunes, which a famous neurologist called Miller Fisher observed when he was cutting up a lot of brains. So he found that there were these just these empty spaces called lacunes on autopsy, and as you know, the subcortical areas, including the basal ganglia, which the M1 segment travels through, are all supplied by the lenticulostriate arteries, branching off the M1 segment, and also the A1, a bit of from the A1 segment of the ACA as well. And there are 5 classic lacunar stroke syndromes. So the one that we see here is a pure motor stroke, and it's indeed the most common type of lacunar stroke syndrome. And this occurs when the posterior limb of the internal capsule is knocked out. You can also get what we call an ataxic hemiparesis, which is the combination of motor and cerebellar symptoms on one side, which occurs when the internal capsule, the basilar part of the pons, and the corona radiata are knocked out. You can get something, dysarthria, or a clumsy hand syndrome, which is a really, really strange stroke syndrome. So patients can't talk, so they're dysarthric. And they have this clumsy hand. The hand isn't actually weak, it's just clumsy on one side. And it occurs when the basilar part of the pons and the anterior limb of the internal capsule are knocked out. Just as you can get a pure motor stroke, you can also get a pure sensory stroke as well, which is when the thalamus is knocked out. And you can also get a sensory motor stroke when both the thalamus and the posterior limb of the internal capsule are knocked out. So that's a lacunar stroke. The next patient that you see is Mrs. AB, a 45-year-old lady who presented with difficulty walking, and then subsequently sensation change on a background of severe dilated cardiomyopathy. So she had a code stroke when she came to ED, and then another code stroke later during her stay. And both times the stroke team initially said that it wasn't a stroke, that was probably a migraine because the symptoms were progressive, which is weird for a stroke. So days later, she actually ended up under cardiology because of her dilated cardiomyopathy. And the cardiology registrar noticed that she had some difficulty doing the finger-nose test on one side. But noting the fact that she had already had 2 code strokes and both of them were deemed not to be strokes, the cardiology registrar initially wrote it off as functional. But then 2 days later, Mrs. AB ended up in the Gen Med unit because no one really knew what was going on with her. And on ward round, the Gen Med registrar noticed that one of her eyes was tosed. And because there was unilateral ptosis, the next thing that he looked at was the pupil. And he discovered that the pupil was small on that side. And the Gen Med registrar went through the history again, and it turns out that the sensation change was on the right side of the face as well as the left side of the body, so crossing sides. And the clumsiness was on the right side. And you also, she also tells you that recently she's had noticed some difficulty swallowing as well. So, I mean, again, putting it to the floor, what stroke does she have and why are the symptoms progressive? So, yeah, so recapping her symptoms, right-sided ptosis and meiosis. So what does this sound like? Ptosis, meiosis, and hydrosis. Horner syndrome. There's sensation change on the right side of the face and the left side of the body. So, crossing sides and where in the CNS do we have some fibers that have crossed while other fibers haven't? It's in the brainstem. She has right-sided clumsiness and also difficulty swallowing, which is a bulbar sign. And the bulbar cranial nerves are located in the lower part of the brainstem. So as as people mentioned, this is a PICA in infarct. What we call lateral medullary syndrome or Wallenberg syndrome. And it's progressive because she's had a vertebral artery dissection on the right side that's affected the posterior inferior cerebellar artery. To sort of sidetrack a little bit to explain this a little more. So that there are these rules of fours in neurology that were made up initially by a neurology consultant that worked at Barwon Health. And the first rule of thought is something that you guys should all be familiar with. So there are 4, cranial nerves above the pons. There are 4 cranial nerves that exit the pons, and then the four cranial nerves that are in the medulla. But the other rule of fours are concerning the brainstem. So as you guys are probably aware, the brainstem can be divided into medial and lateral components, and the medial component contains 4 M's. So the first M is the motor pathway, so it contains the corticospinal tract. Second M, motor nuclei, so it contains the motor nuclei from the motor cranial nerves. So 3, what are the purely motor cranial nerves? Yeah, 3, 4, 6, and 12. Great. Motor pathway is the first M. Second M is motor nuclei of all the motor cranial nerves. So 3, 4, 6, and 12. Medial. So the third M is medial lemniscus. So the brainstem part of the dorsal column, which is responsible for pressure, vibration, fine touch, and proprioception. And the fourth M is the medial longitudinal fasciculus, or the MLF, which if you get that affected in a stroke, causes internuclear ophthalmoplegia. And then the lateral component contains 4 S's. The way to remember, so S for side, lateral component contains the 4 S's. So first S is the spinothalamic tract, which is responsible, as you know, for pain and temperature in the arms and legs. The second is the sensory nucleus of the cranial nerve 5, which is responsible for pain and temperature in the face. Third S is the spinocerebellar tracts, which are responsible for walking and for whether you have vertigo or not. And the final S is the sympathetic tract, which if you knock that off, gives you Horner syndrome. So in this case, if you occlude the left PICA, you knock off the lateral part of the lateral component of the left medulla, which contains the 4 S's. So if you go through, so if you knock off the left spinothalamic tract, then you'll expect the patient to present with right-sided loss of pain and temperature sensation in the arms and the legs. If you knock off the sensory nuclei of the cranial nerve 5, then the patient will present with left-sided loss of pain and temperature sensation in the face. If you knock off the left spinocerebellar tract, then the patient will present with left-sided spinocerebellar signs. So, which is why the patient had a difficult finger-to-nose test on the left-hand side, and the patient will also have vertigo. And then finally, if you knock off the left sympathetic tract as well, and then the patient will present with a left-sided Horner syndrome, so ptosis, meiosis, and hydrosis. And you also knock off the bulbar cranial nerves as well, which are 9, 10, 11, 12. And so you'll get a patient presenting with bulbar signs such as dysphagia and dysarthria, which was part of this patient's constellation of symptoms as well. So the next patient that you see is, so that was PICA, leading to lateral medullary syndrome or Wallenberg syndrome. So the next patient is Mr. CD. So he's a 25-year-old male, was initially sitting at home watching TV, then all of a sudden dropped his conscious state. And then when he arrived in ED, his girlfriend was interrogated regarding, which drugs he'd been using, because usually when young guy sudden drop in conscious state, often ED physicians are trained to look for toxins. So the ED registrar looked at his pupils, and of course they were pinpoint, consistent with a narcotic overdose. But then he kept looking and noticed that the eyes moved in weird ways. There was a bit of nystagmus. So nystagmus, altered conscious state. What could this be? Absolutely. So a basilar artery stroke. As we were saying, basilar artery is formed by the union of the left and right vertebral arteries. So if you knock out the basilar artery, both sides are affected. So it causes what we call a locked-in syndrome. Symptoms of basilar artery stroke. So you have an altered conscious state, weakness in both the arms and both the legs. So classically, you just have complete quadriplegia. But in real life, it's sometimes sort of asymmetrical, but it's always bilateral. And you can get a lot of sort of patients getting a lot of extra movement. So have lots of moving of the arms and legs as well. So these patients have lots of tremor, lots of shaking, and often misdiagnosed as having seizures. Sometimes you can get some mild paresthesias, but sensation changes in a basilar artery stroke aren't the most prominent feature. And then you get these weird eye signs. So you get oculomotor symptoms and signs. So these are quite variable. So patients can present with vertical nystagmus, horizontal nystagmus, contraction nystagmus, which is where like the whole eye is beating in and out of the eyeball. And gaze restriction in all directions. So the classic locked-in phenomenon. And so in a patient, who presents with sudden onset altered conscious state and then weird eye signs, you should think basilar artery stroke. And some patients have bulbar symptoms as well. So due to loss of the medulla and so the nuclei for the last 4 cranial nerves. So these patients can have difficulty swallowing. And so that was a basilar artery stroke causing what we call locked-in syndrome. The last patient that you see on your ward round is a 70-year-old gentleman who had a sudden onset sensation change on his left side. So the neurology consultant on examination found that he had hemianopia. So the consultant then asked him to write down how he was feeling. And then this was in the CT when he was being sort of introduced into the CT scanner. So the consultant asked him to write down how he was feeling and then asked him to read the CT scanner safety instructions on the wall. And weirdly, the patient had no issues writing that he was scared and confused, but couldn't read a single word off the large print safety instructions. So does anyone know what this might be? So have no issues writing, but has difficulties reading. In a patient who presents with, hemisensory loss and hemianopia. So hemianopia, hemisensory loss, is a virtually pathognomonic for a PCA stroke. So almost always points to a PCA stroke, and we'll talk. So this patient had a left PCA stroke. Left PCA stroke. So PCA supplies. So part of the vascular territory for the PCA is the primary visual cortex. So these patients present with contralateral hemianopia with macular sparing. Because the PCA, so you also classically get a hemisensory loss, and the reason is that it affects the thalamus, and if you knock out the thalamus, you'll present with sensory changes. And if it's a left-sided MCA stroke, patients often present with what we call alexia without agraphia. So patients can write fine, but cannot read, which is weird. And the other weird thing that can happen with left MCA stroke is that is what we call anomic aphasia. So patients cannot name objects around the room. So if you present them with an apple, for instance, they won't be able to say to you that it's an apple. Whereas if you have a right MCA stroke, you can get face blindness. So the technical term for that is prosopagnosia. And they have difficulty recognizing faces. So that's a PCA stroke. Going through those, so the 5 different Lacunar stroke types and what's the most common Lacunar stroke syndrome. So the most common one is a pure motor stroke. But you can also get other subtypes like ataxic hemiparesis, dysarthria coupled with a clumsy hand syndrome, pure sensory stroke, or a mixture of a sensory motor, sensory and a motor stroke. But the pure motor stroke is the most common Lacunar stroke syndrome. And what are the 4 M's contained within the medial compartment of the brainstem? So the motor pathways, so the corticospinal tract, the motor nuclei, so the nuclei from the purely motor cranial nerves, 3, 4, 6, and 12. Medial lemniscus, so brainstem, which is the brainstem part of the dorsal columns, responsible for pressure, vibration, fine touch, proprioception. And the 4th is the medial longitudinal fasciculus, or the MLF, which if you knock that off, causes internuclear ophthalmoplegia. And the 4 S's contained within the lateral or the side compartment of the brainstem is the spinothalamic tract, responsible for pain and temperature, sensation in the arms and the legs, sensory nucleus of cranial nerve 5, so pain and temperature sensation in the face, the spinocerebellar tracts, responsible for walking and determining whether you have vertigo or not, and the sympathetic tract, which can give you Horner syndrome if you knock that out. What does occlusion of PICA present with? So this is the Wallenberg syndrome, so lateral medullary syndrome. So 5 components: vestibular and cerebellar signs, sensory symptoms, Horner syndrome, weakness of the bulbar muscles, and also respiratory function. Occlusion of the basilar artery gives you the locked-in syndrome. So the most prominent features being altered conscious state and weird eye signs. And occlusion of the PCA, hemianopia, and hemisensory loss is the classic virtually diagnostic combination of symptoms. And if it's a left-sided PCA, patients can present with alexia without agraphia, so they can write how they feel, but they cannot read. All right, so that was a Cook's tour through all of the different stroke syndromes that you would commonly see. I want to turn more now to sort of the real world clinical setting, in terms of if you have a patient being rolled in through ED who under a code stroke is suspected to have one of these stroke syndromes, how would you manage the patient? So suppose you had a patient come through ED with altered GCS, right-sided hemiplegia and hemianesthesia, and global aphasia. Firstly, what is this constellation of symptoms suspicious for? What kind of stroke syndrome? Altered GCS, right-sided hemiplegia and hemianesthesia, and global aphasia. Yep, so M1 segment, so a proximal MCA stroke. So this is similar to what our first patient had. And imagine you're the neurology registrar or the stroke fellow. How would you manage this patient? So in ED, the first step is obviously to ensure stabilization. So to go through your ABCs. So ensure stabilization of the airway breathing and circulation. The next step, and you may or may not be able to do this, is to take a history and perform an examination. And usually this is quite brief, because as we all know, time is brain. So we can't afford to waste time asking questions and performing examination steps that aren't absolutely critical. But if you're able to take a history, and even if you're not able to take a history from the patient itself, you often need to rely on collateral history from say family members, co-workers, or paramedics. There's an important thing that you always need to clarify on the history, and that is the time of symptom onset. Or failing that, if no one can tell you exactly when the patient first experienced the symptoms, when the patient was last known to be well in front of their family members, for example. And do you guys know why time of last wellness or time of symptom onset is so important to glean? Yeah, great. So there are two definitive treatments for an ischemic stroke. So one is thrombolysis, so with IV alteplase, and the other is mechanical thrombectomy. And both of them are time sensitive. So fantastic. Yeah. So that would have been my next question. So IV alteplase or IV thrombolysis is has been shown to be only effective in the first 4.5 hours after symptom onset. After that, you can give IV alteplase, but it doesn't really make a difference. Whereas mechanical thrombectomy, or what we call endovascular clot retrieval, or ECR, do you guys know what the therapeutic window there is? Yeah, so initially said to be 6 hours. Now, more and more studies are showing that you can sometimes push it out to 24 hours. So in the first 6 to 24 hours after symptom onset, after that, certainly after 24 hours, mechanical thrombectomy makes no difference. Which is why, in order to calculate, are you within the therapeutic window for these two definitive therapies, you need to know what the time of symptom onset is. Now, if you have a chance to talk to the patient, then, or to take collateral from family members or co-workers, then the rest of history, if time permits, should be aimed at excluding stroke mimics. So, patients with an altered GCS, right-sided hemiplegia, hemianesthesia, global aphasia, doesn't necessarily need to be presenting with a stroke. There are many different things that can what we call classic stroke mimics, and these include things like seizures, syncope, migraine, hypo and hyperglycemia, and drug toxicity as well. So asking questions to try to include or exclude those stroke mimics are important if time permits. Now, moving on to the physical examination. Now, often the neurological examination that we were all taught in med school isn't necessarily the first go-to examination that neurology registrars will perform if given the opportunity to do so. There's a standardized neurological examination called the NISS examination, or NIHSS examination, which involves 11 sort of major steps, which I've listed out on the slide there. I won't go through them all, but it's the standard examination that we perform at presentation for patients suspected of having a stroke, and in the days after to quantify the severity of the stroke. So you go through the 11 steps of the examination, and you score the patient based on their response to at each step, and that ultimately gives you a score that can go from 0 to 42 that quantifies the severity of a patient's stroke. So usually a NISS score of less than 5 indicates a mild ischemic stroke. 5 to 9 indicates a moderate ischemic stroke, and then beyond 10 or above indicates a severe ischemic stroke. As I say, I won't go through all the steps of the NISS exam here, but it's worth looking taking a look online before any stroke rotation, because it's probably the most common exam that you will see being performed. And if you're working on a stroke unit as a junior doctor, you may be asked to perform a NISS exam to quantify stroke severity during a ward round. So So you've done a history and you've done an examination. The next step is to order investigations. And remember, again, time is brain. So we can't afford to fluff around for half an hour trying to take bloods from a patient. But bloods, if you can get them, sometimes can be useful. There's only one test, before you subject the patient to IV alteplase therapy. There's only really one test that is mandatory. Do you guys know what that is? No, often alteplase, if you're actually suspecting a stroke, So a non-con CT brain, if you can do it, is useful. But if clinically the patient is is presenting classically with an ischemic stroke, often you can start IV alteplase even prior to non-con CT brain. Yeah, it's glucose. So Josh, can you explain why?
Hypoglycemia is a stroke mimic. That's all you need to say. Yeah,
whoever that was. Yeah, so hypoglycemia is a stroke mimic. So a BSL of less than 2.7 is a there's a list of contraindications for strokes, and BSL of less than 2.7 is an absolute contraindication to IV alteplase. So we need to rule out hypoglycemia first and correct that before we subject patients to IV alteplase. So we mentioned non-con CT brain. The most critical investigation to perform is the non-con CT brain. And the non-con CT brain is good for three things. So it's good for, as we spoke earlier during the lecture, it's good for differentiating ischemic stroke from hemorrhagic stroke. It's very sensitive for diagnosing hemorrhagic strokes. The second is detecting early infarct signs, and the third is, as we said, the detecting the hyperdense vessel sign. So you can sometimes see a clot in the vessel as the hyperdense vessel sign. And the utility of a non-con CT brain is further enhanced by the addition of two more CT modalities. So the first is, and both of which we've mentioned already in this talk. So the first is the CT perfusion scan, and the other is the CT angiogram. And together, these three CT modalities we call a multimodal CT. So CT angiogram, so CTA, sometimes called a CT cow, so CT circle of Willis, is performed, as we mentioned, by administering a bolus of iodinated contrast rapidly through a peripheral line in the antecubital fossa, and then you get CT imaging. The CT imaging is timed to capture the arrival of the contrast in the brain vasculature. And if you have a clot, that classically causes a filling defect in the vessel on CTA. And a CTA, for that reason, is quite good at detecting intracranial large vessel stenosis and occlusion. And then you have this, so on the diagram there, so top left-hand panel is the non-con CT brain showing the hyperdense vessel sign, and on the right is your CT cow or the CTA showing that filling defect. And the third CT scan that we commonly do is a CT perfusion scan. So this consists of a series of CT scans that are obtained, again, following the injection of an IV bolus of contrast. And the good thing about the CT perfusion is that using quite complicated, maths and physics, it's able to identify for us or estimate for us where the ischemic core is and where the ischemic penumbra is. I'm sure you guys have heard of the core and the penumbra, but the core is where, the tissue is well and truly dead, not salvageable. And the ischemic penumbra is the area around the ischemic core that it can potentially be salvaged if you get rid of the clot early enough. And other investigations that would be good if you have time would be an ECG, because often in patients presenting with a stroke, especially if it's of an atherosclerotic in nature, these patients are at high risk of concomitant acute coronary syndromes as well, and which can be detected on ECG. And obviously you want an ECG to rule out, arrhythmias that can predispose to embolic events such as atrial fibrillation. So, you stabilize. So patient comes into to ED, code stroke called. You're highly suspicious of a stroke. First thing to do, stabilize the airway, breathing and circulation. And then if you can, take a history, clarify what the time of symptom onset is. Try to rule out your stroke mimics through history. Physical examination. Most often we'll do the NIS examination, and you'll score the patient on a scale from 0 to 42, and that quantifies a stroke severity. And then in terms of investigations, the only thing that that is mandatory before you give a patient IV alteplase is to check their BSLs, because hypoglycemia is a stroke mimic, and a BSL of less than 2.7 is a contraindication to IV alteplase. So if the patient is hypoglycemic, you fix their sugar levels, bring them back up to normal range, and they're still presenting with persistent symptoms, then you go ahead with the alteplase. Investigations, the only really important investigation in the context of a stroke is the CT brain. It starts off with a non-con CT brain, and then you can add a CT angiogram and a CT perfusion, which identifies the core and the penumbra. And if you have a salvageable penumbra, then that's more of an indication that you should proceed with those definitive treatments for ischemic stroke. But before we talk about that, there are some things that you should keep at the back of your mind when you're managing a patient presenting with acute stroke. So the first is fluids. Because especially in older patients, they can be presenting with stroke, and they can be intravascularly deplete at the same time. And being intravascularly deplete is bad in the context of stroke because it worsens cerebral blood flow. So if you're, if you're suspecting that the fluid status is hypovolemic, give normal saline. The other thing is that so hypoglycemia can mimic stroke, but hyperglycemia has been convincingly shown to lead to poorer functional outcomes in a patient that's being definitively managed for an acute stroke. So usually when we're giving IV fluids, we tend to avoid any solution that contains dextrose because it can worsen hypoglycemia if the patient is hypoglycemic. We tend to just use stock standard sort of normal saline, CSL, etc. So we talked about hypoglycemia, we talked about hyperglycemia as being associated with poor functional outcomes. If a patient's BSL is greater than 10, therefore you should treat it with stat doses of Novorapid to bring the patient's BSLs back down to normal range before proceeding with IV alteplase therapy. The other thing that you need to think of is that often, patients present with bulbar symptoms such as dysphagia, and that places them at quite significant risk of developing aspiration pneumonia. So often in these patients, we tend to keep them nil by mouth, and until we can get a speech path to do a formal swallowing assessment. This is important because a lot of the medications that we give in the acute setting for a stroke are oral medications, and we'll talk about what medications we give. But one example is aspirin. If you're really worried about aspiration pneumonia, giving oral aspirin, aspirin can be given per rectally. And things like head and body position, 30 degrees has been shown to be, the ideal sort of elevation of the head of the bed for stroke patients, especially if they're at risk of elevated intracranial pressure from cerebral edema, which can occur 24 hours after a stroke in patients with large ischemic infarction, and also so in patients with a risk of aspiration as well, you wouldn't want them completely lying flat. So 30-degree elevation. Fever is also associated, just as hypoglycemia is. Fever is also associated with unfavorable outcomes in stroke. So if a patient does have a fever for some reason, we treat it quite aggressively with simple antipyretics like paracetamol to bring the fever down. And the most important thing is blood pressure management, because so usually the blood pressure is elevated in stroke patients, and this is can be due to chronic hypertension, or it can be due to an acute sympathetic response in relation to the acute stroke. And so guidelines have variously sort of recommended a blood pressure of below 185 on 110 before IV thrombolysis to optimize outcomes. Right, so going to the definitive treatments for stroke. So there are two, as we said. So IV thrombolysis with IV alteplase, which has been shown to be effective within 4.5 hours of the time of symptom onset. And mechanical thrombectomy, also called vascular clot retrieval, which has been shown to be effective within 6 to 24 hours of symptom onset. Now, for most patients with acute ischemic stroke, IV alteplase is the first line therapy. But it's only effective within 4.5 hours of symptom onset, which is why it's so important to document the time of symptom onset, or failing that, the time that the patient was last known to be well. So there are a number of contraindications to IV alteplase. I think the ones that you need to bear in mind is the BSL less than 2.7 is a contraindication to IV alteplase, and the other one is blood pressure as well. We need to lower the blood pressure to below 185 on 110 before administering IV alteplase. So if the stroke is due to an occlusion of a large vessel, like the proximal MCA or the basilar artery, and you usually pick this up using a CT angiogram, mechanical thrombectomy is effective, but only if performed within classically within 6 hours of symptom onset. And there's recent studies showing that mechanical thrombectomy can still be effective in patients presenting 6 to 12 hours after symptom onset, including those who wake up with symptoms. So in patients who wake up first thing in the morning, they discover these neurological deficits. We don't actually know exactly how long they've had the symptoms for. Especially in those patients, it's been shown that actually within 24 hours, mechanical thrombectomy can still be effective. And if the patient is eligible in the time window for both IV alteplase and endovascular thrombectomy, both treatments can be given in the one patient. So after the event, so you've performed. So a patient has arrived in ED 2 hours after symptom onset. They fit the you've done a BSL, and their BSL is 5. you've done a blood pressure and the blood pressure is normal at 125 on 65. You can it fits the time window for IV alteplase. It fits the time window for mechanical thrombectomy. You can give patients both. So you give the patient IV alteplase and then do endovascular clot retrieval afterwards. But then, so that deals with the acute stroke, and hopefully, you've gotten there in time to save a large portion of the ischemic penumbra. But then afterwards, you need to try to think about secondary prevention of stroke, because in the 24, 48 hours after a stroke, that patients are at high risk of a stroke recurrence. And so there are a couple of things that you classically need to think of. So carotid endarterectomy, I think someone had a question about this earlier in this talk. So do you know when we would think about performing carotid endarterectomy in patients who have suffered from an acute stroke? Yeah, that's right. So firstly, you need to, I guess, confirm in your head that the stroke was in the territory supplied by the carotid artery. So if the infarct is in the brainstem, like even if you think you've heard a carotid bruit, the carotid artery was obviously not the culprit for a brainstem infarct. So you need to make sure that the clinical presentation is consistent. And then yes, you can do usually the CTA is able to characterize the extent of occlusion of the carotid artery. If not, you can pair that with a carotid Doppler ultrasound. But an indication for carotid endarterectomy if you get more than 70% stenosis of the carotid artery. It's effective when the patient has the procedure within 2 weeks of an ischemic stroke. So carotid endarterectomy, if you think that the stenosis or occlusion of the extracranial carotids is the culprit, and the syndrome fits, and on CTA the carotid artery is more than 70% stenosed, then you'll organise for the patient to have a carotid endarterectomy to clear that stenosis or clot. In a patient who has AF and who you suspect might have developed a stroke because of their AF, if they're not on anticoagulant therapy, you should place them on anticoagulant therapy. As you guys probably know, the first line agent for anticoagulant therapy are your DOACs. And they've largely replaced warfarin for stroke prevention in the setting of AF. There are mainly two populations of patients where you would really think about giving them warfarin rather than DOACs. Do you guys know in what setting you would probably give warfarin over DOACs? Yep. So one is valvular AF, and the strict definition for valvular AF is a patient with AF plus mechanical heart valves or plus a moderate to severe mitral stenosis. There's another patient population that you would consider. Yeah, that's right. So you should know that in patients with a creatinine clearance of less than 25, apixaban is contraindicated, and indeed, a creatinine clearance of less than 30, dabigatran and rivaroxaban are contraindicated. And just while we're on that, so warfarin a lot of people talk about, reversal agents for when, these warfarin or DOACs are being used in a patient who is acutely bleeding. And this applies to patients who's presented with an acute ischemic stroke, but has in the days after developed a hemorrhagic transformation of their acute ischemic stroke. In that context, often we talk about reversing the anticoagulant agent. Do you guys know how we would reverse warfarin? Yeah, so vitamin K is really slow to act, but certainly something that we give. So IV of 10 milligrams of vitamin K. But in the acute setting, FFP is used. And in DOACs, so do you guys know the reversal agent for dabigatran? Yeah, so or the trade name for it is Praxbind. So it can be reversed, and the reversal is immediate and sustained. And there's now quite a lot of experience with reversing dabigatran using Praxbind and then giving sort of acute thrombolysis for ischemic stroke. How about the direct factor 10A inhibitors, so apixaban and rivaroxaban? Yeah, so it's something called andexanate alpha, and we don't have it in Australia. It's used mainly in the US, but it's not as good an agent as Praxbind. So the reversal is quite slow and not sustained. So comfort levels around reversing direct factor 10A inhibitors using andexanate alpha is quite low at the moment. Cool. And just while we're talking about sort of anticoagulant, antiplatelet agents, so antiplatelet, so there's this concept of triple therapy, placing patients on triple therapy after an acute stroke event. So acute therapy includes antiplatelet therapy, blood pressure lowering therapy, and lipid lowering therapy. Antiplatelet therapy, do you guys know the guidelines around what agent we give and for how long? Yeah. So thinking through the I guess case that we had before. So we have a patient who was within the therapeutic window for both IV alteplase and mechanical thrombectomy. Comes in, we'll give IV alteplase, we'll perform mechanical thrombectomy. Usually you would withhold, hold off on giving any antiplatelets or anticoagulants for at least 24 hours after IV alteplase therapy. But then after that 24-hour period has elapsed, you'll start patients on antiplatelet therapy for as soon as possible, unless it's contraindicated. And usually, so it's based on the NIS score, so NIHSS score. So if the NIS score is less than or equal to 5, so what we define as a minor ischemic stroke, then we tend to give dual antiplatelet therapy for. So depending on the cause of the stroke, for either 21 days, sometimes out to 90 days, and then switch the patient onto single agent antiplatelet therapy. And if the NIS score is above 5, so moderate to severe, then we tend to just give aspirin. And do you guys know why that is the case? So if it's a mild one, you'll give dual antiplatelet therapy for the first couple of weeks, and then switch to single agent. If it's a bad stroke, then you tend to, that's right. So it relates to the risk of hemorrhagic transformation and the volume of the infarcted. If you have a minor stroke, the volume of infarcted tissue is likely to be quite small, and so the patient's not at as high risk of a hemorrhagic transformation. But if the NIH SS score is above 5 and you have a major stroke, the volume of infarcted tissue is likely to be quite large, and there's a higher risk of hemorrhagic. Tend to go a little less hardcore with the. So blood pressure lower therapy, we tend is also quite standard, so part of the triple therapy, and you know, so Australian guidelines recommend that all stroke patients with a blood pressure of above 140 have long-term blood pressure lowering therapy, either indicated or if they were already on blood pressure lowering therapy to intensify. And lipid lowering therapy, do you guys know what we usually make patients? Lipid lowering therapy. And at what dose?
You know, I'm very interested in this car, but it would be great if you could wait for me.
Yep. So high dose lipid lowering therapy is usually atorvastatin 80 milligrams daily.
For 2 to 3 months.
But often you need to be aware of intolerance. So often elderly patients can become intolerant of such a high dose of atorvastatin, complain of myopathies, etc. At which point we will step down.
Because I need to,
great. So quiz. So what's the therapeutic window for IV alteplase?
Like, honestly, I don't think it's a good thing to like buy a car without inspection.
Hey Mania, you might want to mute because you're not muted.
Transfer for
I think the host should be able to mute her mic.
Oh, great. Okay. Did that solve the issue? Sorry, Mania.
গরম লাগতেছে আব্বু, I'm so hot. আমার ফ্যানের নিচে থাকে না, কেন গরম লাগে? তোমার সেগুলো বলাও যায় না, তুমি তারপরে ভাববা আমার জ্বর আসছে নাকি, কিছুই হয়নি, just super tired. My পরীক্ষা was like okay, not the best.
Did that work? Okay. Great. Okay. Therapeutic window for IV alteplase. 4.5 hours. Therapeutic window for mechanical thrombectomy. Yep, 6 hours, sometimes pushing out to 24. And there are various criteria to when we're allowed to push it out to 24. So the NIST score is a standard examination that we perform on all patients with ischemic stroke to quantify the severity of the stroke. And you calculate the NIST score by going through the 11 steps of the examination and then scoring it based on the patient's response. How do we define mild, moderate, and severe ischemic stroke based on the NIST score? Yep, so less than 5 is minor, above 5, so 5 to 9 is usually moderate, and then 10 or above is severe. The only test that's mandatory prior to IV alteplase is BSL, because hypoglycemia is a stroke mimic. What's the difference between non-con CT brain, CTP, and CTA? It's quite an involved question, but non-con CT brain is usually the first thing that you do. Very good for distinguishing hemorrhagic stroke from ischemic stroke, and sometimes can pick up early ischemic signs, and as well as the hyperdense vessel. So you can sometimes actually see the clot on non-con CT brain in it, because that can exacerbate the hypoglycemia. When is carotid endarterectomy indicated post-stroke?
Under 2 weeks.
Yep, under 2 weeks. 2 other criteria.
Greater than 70% stenosis.
Yeah, greater than 70% stenosis. Usually you can pick that up on CTA. Sometimes it requires a carotid Doppler ultrasound. And obviously the stroke syndrome has to be consistent with one that's caused by a thrombosis forming in the internal carotid artery. So if you have a patient presenting with what sounds like a brainstem infarct, then obviously, even if the carotids are severely stenosed, it's not the culprit for that particular stroke event. So how do you reverse warfarin? Acutely, what do you use? FFP. So over the long term, you use vitamin K. How do you reverse dabigatran? So the drug is Praxbind. So now we have quite a bit of experience of using for patients who present with the stroke, who's already being anticoagulated with dabigatran. We have experience in giving Praxbind as a reversible agent. It's very quick in onset, very effective, and then giving them IV alteplase. And how do you reverse factor 10A inhibitors? Well, the short answer to that is you can't really in Australia, but there are agents that you can use in overseas to reverse factor 10A inhibitors, but these are slow in onset and it's not as effective. So at the moment we don't have that much experience with reversing them and then giving IV alteplase. What's meant by triple therapy post-stroke? Yep. So in terms of antiplatelet therapy, so after IV alteplase plus or minus mechanical thrombectomy, we withhold for 24 hours and then start patients after 24 hours on antiplatelet therapy. How do we determine whether we start them on dual antiplatelets or just a single agent antiplatelet therapy? So it's based on the severity of the stroke. So if it's a minor stroke, so severity, so NIS score of less than 5, then we can go a little more hardcore with the antiplatelet platelet therapy and give them dual antiplatelet therapy. And I forgot to mention this. What's dual antiplatelet therapy? What do we mean by that? Yeah, clopidogrel plus aspirin. And often, even in ED, if you're rotating through ED, you might be asked to chart this for a patient coming in with like a suspected TIA, for example. Do you guys know what you need to chart if a neurology registrar tells you, okay, put this patient on 3 weeks of dual antiplatelet therapy and then step down to single agent? What do you actually chart on discharge?
Isn't clopidogrel 300 loading, then 75 afterwards?
Yes, correct. And aspirin?
300, then 100?
Yes, correct. Yeah. So for dual antiplatelet therapy, you need to load the patient. So we usually start at within 24 hours after a patient present with an acute ischemic stroke, we load both aspirin loading and clopidogrel loading are 300 milligrams. Sometimes some institutes, and it varies between institute, but some institutes go as hardcore as clopidogrel 600 milligrams for loading. But the maintenance doses are all the same. So aspirin is 100 milligrams and clopidogrel is 75 milligrams. And you keep that depending on what the etiology of the stroke is. You can keep the patient. You most commonly keep the patient on dual antiplatelet for 21 days and then switch to single antiplatelet therapy. And what is single agent antiplatelet therapy involve? Load just means 1 dose. The first dose, yeah. So actually, single agent antiplatelet therapy, there's evidence to show that clopidogrel single agent is better than aspirin single agent. So often, you know, we keep the patient on dual antiplatelet therapy for 3 weeks and then switch them over to single agent clopidogrel. But of course, if the NIS score is above 5 and the patient has had a major stroke, then we don't give any dual antiplatelet therapy. We just continue with single agent antiplatelet therapy. And the other thing to raise is that triple therapy, so giving patients dual antiplatelet therapy plus anticoagulation is a bad thing. So we almost never, there's almost never an indication for triple anticoagulant antiplatelet therapy. And that answers question 10. So great. Sorry, a little bit over time, but that brings us to the end of today's talk. Thanks everyone for coming and supporting our cause. The next virtual ward round series is going to be on general surgery, and it will be again same time, same place, Thursdays 2 weeks from now. Yeah, there's a sign up code there, and I hope everyone has a good rest of the evening.